Uh, this is still not a complete talk in the sense. Artificial intelligence in lung cancer is a huge topic. It can be done in several, it is used in various roles. But here I want to focus on artificial intelligence in early lung cancer detection because that is more relevant to diagnose cancer at this stage. This is the next stage. So again, we know that the lung cancer is a deadly cancer. It has the highest mortality. It has got it causes more deaths than cancer deaths from breast, pancreas, and colon combined in men. It is more deaths than prostate, colon, and pancreas in men. So it's the deadliest cancer. So the overall survival is dependent on the stage at which we make a diagnosis. If you diagnose the cancer early on, the prognosis is good. So therefore, it is important to diagnose cancers early on. So most of the lung cancers, they start as lung nodules. Unfortunately, we do not know which nodule is a cancer unless we monitor it carefully. A nodule which increases in size is more likely to be a lung cancer. And of course, it should be the proper clinical context of being a high smoker and other things. There are a number of problems with lung cancer screening. I told you we cannot assign a lung RAS category. That's a challenge. We pick up a nodule, but we assign it wrong to lung RAS category. Therefore, we miss the chance of making early diagnosis. Then there are so many other different tools which are available. There are functional guidelines, KRAS, we have KRAS, lung RAS, all these things. So we cannot use the proper reporting system for this nodule. We do not help these patients. So therefore, we'll see how this is going to progress. I introduced the concept of artificial intelligence. I want to repeat it one more time, though I'm repeating myself. Artificial intelligence is anything where a computer performs the task that requires human intelligence. If computer is doing something which you alone can do so far, that is artificial intelligence. A machine learning is a step further, where a computer has the ability to learn without being explicitly programmed. So artificial intelligence in the machine learning process can get better and better. So you must be aware of artificial intelligence in various aspects of your life. So this is what it does. So I told you that artificial intelligence is a few different ways of developing. One is the imaging data. But there are several other applications of artificial intelligence where imaging data is not even needed. So as a radiologist, we use imaging data. Then imaging data in conjunction with the other tabular data enhances the predictability of a artificial intelligence tool. So each of these go through different tracks. To process the imaging data, we have to use different type of software programs with convolutional layers, pooling layers, and so on and so forth. For the tabular data, we use different type of tools, like random forest or GPU. So finally, we get a product and use this product to in clinical practice. So the first, because the lung nodule detection, early cancer detection is a complex problem. Because first, you have to pick up a nodule. You cannot not identify a nodule. If it is a nodule that can become a cancer, you miss the goal. Then, after we identify a nodule, we have to properly identify the various categories of nodule. It's a ground glass nodule, hard solid nodule, a solid nodule. If you are using a Fleischner or a lung RAS category, we should properly assign a category to this particular nodule. Then, to track this nodule, we should be very accurate in our measurements. What if you're following the nodule every year, but you're missing the increase in the volume of flies? Then again, we miss the chance of making early diagnosis. So we should be able to consistently and accurately measure the dimensions and the volume of this nodule. That is the same longitudinal stability or change in the nodule size. Then, of course, we also have to pick up the other incidental findings, which may affect the prognosis in these patients, such as pulmonary artery calcification, sarcopenia, and all others. So let us walk through a few systems of few key features in different AI systems, but there are a few things which are common across all these AI systems. The first thing is the AI system will detect a nodule or early cancer. Then once it identifies a nodule, then it analyzes the nodule. It tries to figure out what is the malignancy risk in this particular nodule. What is the texture of this nodule? What are the borders of this nodule? Is it a stipulated border, globulated border? Is there any fat or calcification in this nodule? So it tries to analyze the texture. So first you identify the nodule, then analyzes the texture of the nodule. Then it monitors the nodule for a period of time. Is this nodule changing in size, shape, density? Suppose a pure ground glass nodule subsequently remains of the same size but has increased in density, that's a change. That is important to know. So it monitors the nodules across various aspects, size, volume, density. Then finally, this AI tools have the ability to grasp all these findings from your images and generate a report, and you can export it to your final report. This is something most of these AI systems are capable of doing. So how does it work? So for example, you have a stack of images. You take this stack of images, from this entire chest images, you subtract out the media sternum, subtract the bones and everything, then you just get the lungs. This is a matter of few seconds. It doesn't take too long. Then within the lung itself, it further segmentize the lobes of this particular lung. First divides into right lung, left lung, and within the right lung it can divide into three lobes, left lung into two lobes. Then within the lobe, it tries to identify the nodule. As you see here, it is less than 10 seconds, less than 20 seconds. Then in 5 seconds, you identify the nodule. Then it tries to analyze the texture of the nodule. Is it solid, par-solid, or a non-solid, like a ground glass nodule? Then it gives you final analysis of the nodule. So it takes only a matter of few minutes for you to get an entire picture of this nodule or potential cancer based on one system. There's another system. There, it also tells you the growth and shrinkage of this nodule. And the follow-up is this nodule increasing or decreasing. We know that increasing nodule is more suspicious for cancer, so therefore it gives you. When you compare the performance of the AI to non-farm CT scans, the pulmonary regions, the AI has got a very high sensitivity of 98%. The specificity is also pretty good. So this is not as good as the radiology itself, because once the radiology shows the nodule, you use some other intuitive thinking to figure out more about the nodule to predict the malignancy of this nodule, or you do not know how they are reaching their conclusion. So this is very comparable to radiology. In the third system, it also has ability to separate out the solid component from the ground glass component of the nodule. So it tells you the overall volume of the dimensions of the subsolid nodule, and within the subsolid nodule, it identifies the solid component and the ground glass component, and it subtracts out and gives you more details. So as you go on, so there are further and further improvements from segmentation of the lungs, segmentation of the lungs into the lobes. Within the lobe, identifying a nodule. Then within the nodule, analyzing the structure of the nodule and change over time in the nodule. Then passing out the changes in the subtle features of the nodule, such as solid component and ground glass component. These are all the things which AI tools are capable of doing, and many of these features are already here. They are available out there for clinical use. So I want to touch upon some of the stuff, like how it is changing our practice. So for lung cancer screening, now we usually use this lung result subtraction algorithm, where we subtract out the results. But what are the advantages? One, we can pick up more ground glass nodules than is possible when looking at the lungs with their results together. So that's the first advantage. The second advantage you see here, when you look at the radiologist performance, one's first radiologist, second radiologist, without result subtraction and with the result subtraction, you see that the performance of the radiologist significantly improves when you use result subtraction. So you pick up more normals. The second thing is, you take a subsolid nodule, which looks like a pure ground glass. If you do this subtraction techniques, you can see more within the nodule. You can identify the subtle solid components in the ground glass nodules. We know that when a solid component is present and it is increasing in time, increasing in size over time, it's more likely to be a cancer. So it tells you that this is a more likely cancer. So these are the things which are possible when you do subtraction. The other thing is, we said there's a challenge in assigning a Langerhans score for this nodule. Okay, we have seen a nodule. Now you have to treat the cancer risk. We know the cancer risk is predicted based on the Langerhans score. If somebody has a Langerhans score of 2, the risk of cancer is less than 1%. On the other hand, if the lung cancer score is 4x, you know the cancer is very high. So it will be useful if this software tools here can provide you with a number. So these tools are out there which provide you the lung RAS score. For example, this particular nodule, it assigned a lung RAS score of 4x. Not only that, it tells you why it has chosen a category of 4x. Because by 4x, by definition means this nodule has some additional features which increases the probability of cancer. So here it thinks that this is a very highly likely to be a lung cancer because it has got speculation. So this one has checked the box for speculation. And furthermore, it has also not seen findings which favor a benign nodule, such as presence of fat or calcification. These two are not present. So then it is also capable of measuring the volume of this nodule. We are not capable of measuring the volume. We measure the longest axis. We do the bidimensional measurements. We can get the mean of the field, but we cannot measure the volume. But these software tools can give you the volume. If you look at the recent lung cancer screening trials at medicine, and even the latest iteration of the lung RAS lexicon, volume measurements are becoming popular. So we have to use volume. Because change in volume is a more accurate picture of the nodule being a cancer. So this is what it does. So this is what you get with the new AI tool. So it does everything for you. So all you have to do is confirm whether these findings are good or not, whether you want to accept this finding or you want to reject the finding. So this is another thing called drop score. I'm not sure if you are aware of this drop score entity. Drop score is if somebody is a male and smoker, they can put those details into their score, they calculate it. It gives the risk of a nodule being cancer. This is nothing to do with even doing the CAT scan. So if you do lung cancer screening, you can always look at drop score and say, this is my age, this is my sex, this is my smoking history, and what is the risk of cancer? It gives you a cancer risk. So you can combine the drop score, which is more based on picture data and other history, with the findings on the lung nodule, then you can generate a comprehensive score. Now this score shows you that this is very high risk for being a cancer. So this is something which is awesome. Many other tools out there which are doing this work already. So then we said for a nodule, we are always trying to find out whether it's a benign nodule or a malignant nodule. Unfortunately, there is no tool out there which can separate out benign nodules from malignant nodules with a high accuracy. The AUC value is okay, it is not perfect. So still we have to follow many of these nodules by doing repeat scanning and see if they are growing inside. So it is helping, but not to an extent where we can generally see longitudinal scan. Then we talked about loss detection. By instead of doing this, following this nodule, by doing repeat CTs, if I incorporate AI algorithms into your nodule evaluation, we can figure out which nodules have to be imaged more frequently, or which nodule needs to be biopsied. We can generate a score, and this is a paper I cited before in Journal of American College of Radiology. By incorporating these other parameters into the nodule dimensions, nodule morphology, you can actually figure out a way to reduce the cost. So this was what they achieved by incorporating these other parameters into AI software. So now, because we are all afraid that AI tools will take away our job, we are going to detect more nodules. How does it, what is there out there in literature? How does AI compare to radiologists? One is, AI tools are very good. They are very, very sensitive, but their accuracy is not. Their specificity is only 50. So there are too many false positives. Then, among the nodules, there are some nodules which AI tools are not great. They are not very good for pure ground-glass nodules. Radiologists are much better. There are tools out there, visual suppression technique, which enables you to see more nodules clearly, but it is not detecting this nodule. It's only making your job easier, but it is not reporting. So, AI software ability to detect or tag a nodule, which is of pure ground glass, is much lower than that of radiologists. So, and also humans outperform the algorithms for detection of atypical lung cancers, such as say a cystic nodule, consolidated mass. So these are some of the things which humans can do better. So overall, like these AI tools are like secondaries to radiologists. They help you, they add value to you. So instead of replacing you. So this is something an interesting study we did. What we did was, in the NLST arm, we know that CAT scan was better than chest X-rays for detection of early cancers. So some cancers were not detected by radiologists on chest radiography. So this company developed a software. We used this software on the X-rays, which were actually from NLST data. We could access this data. So this program had applied to radiographs. It picked up several cancers much earlier than radiologists reported. So it actually is a little more sensitive, therefore it draws your attention to a particular finding, thereby saving time, and thereby also gives you a chance to diagnose lung cancer at an early stage. So we talked about different types of soft tools like deep reconstruction algorithm, which I told them that these artifacts are less. By doing so, it does not affect the constitutivity of nodules. So doing this type of different type of deep learning algorithms, the cystic nodule early cancer is still seen on different type of reconstruction. So whenever you're using neuroimaging techniques, particularly those which are using artificial intelligence as a basis, you want to make sure that it is not upscaling any of the relevant findings, which is not introducing more artifacts into the images. So far, it looks good. Then I talked about AI-based deep noising. The reason I'm showing this again is, if you improve the image quality, you can detect nodules better. And when you detect subtle nodules, these could be potential early cancers. Therefore, you have a chance of making a diagnosis of the cancer at a much earlier stage. So not only this, AI is developing very rapidly. So I'm sure you know that there is something called photon counting detector CT. This is not really widely available now, but there are a lot of literature or some papers out there which are using AI technology to keep up with the newer CT techniques such as photon counting detector CTs. So this is our side. So how will AI evolve in the next few years? One is we will use more AI with the electrical arm along with our diagnostic studies. Then we use AI to look more into the lung cancers, we figure out more of genomics. Then we'll try to correlate the findings of CT scan images with some other blood tests to understand more about the nodules. All these are the goal of detecting cancers at a much earlier stage to improve the prognosis. So, but we're talking so much about AI, you're also mindful of first and foremost is the cost. Cost of AI. If you're using AI in your practice, are you going to get more reimbursement? Or still you have to charge the same amount for your CAT scan, so you're using this expensive AI. That is something you have to see about. And because you're improving your accuracy of your reporting, that gives me cost savings. So that it really helps you, because you cannot invest so much in technology that it will not be cost effective. So at the same time, you should also think about those things. So one way it is going to help you is by using AI tools, radiologists will become more good. So if you are reading right now 4 CT scans or 5 CT scans per hour, maybe you can read 8. So the investment you make in buying this technology will increase your productivity. So that is one way you can say that it is having some cost savings, because the radiologists are becoming more productive. So that helps. So that's one way to look at it. But still, it's a lot of cost. So the other thing would be, because as over time, and more AIs are being developed, so some become very good, popular, and once they become more widely accepted and used, cost will come down. So then it becomes probably more cost effective.